So welcome everyone. Thank you for joining us for today's questions and expert sessions. My name is Rebecca Armstrong, and I'm the Director of Patient Education and Engagement with the Canadian Breast Cancer Network. So before we get started, I would like to cover just a few housekeeping items. The session is being recorded and will be available on our website for anyone who may have missed it or who wants to rewatch it. And I'll send out a link once the recording is available. In the meantime, you can find our previously recorded webinars on our website. I'd also like to take a moment to extend our appreciation to our sponsors for this event. So Pfizer, our gold level sponsor, Gilead, our silver level sponsor, and Bayer, Tricera, and AstraZeneca, our bronze level sponsors. So our questions and expert sessions are strictly dedicated to answering questions, and there will be no presentation from our speaker. She'll just be answering live questions from participants along with ones that have been submitted in advance. You can use the Q&A button that's either at the bottom or the side of your screen to submit your questions, and we'll aim to take as many as possible. Our speaker will do her best to answer your questions, but please note that she won't be able to comment on individual medical situations. And I'd now like to welcome our host for the session, Kathia Mendelea, who's the chair of the board for the Canadian Breast Cancer Network and has the lived experience of being diagnosed with breast cancer herself.
Thank you, Rebecca. Welcome, everyone. Thank you for joining us. I am pleased to welcome Dr. Kelly Metcalfe, who will be joining us to answer your questions about hereditary breast cancer. Dr. Metcalfe is a professor and associate dean of research at the Lawrence S. Bloomberg Faculty of Nursing and the Faculty of Medicine, Department of Surgery at the University of Toronto. She is a senior scientist at the Women's College Research Institute, where her research focuses on the prevention and treatment of breast and ovarian cancer in high-risk women, most specifically those with BRCA1 or BRCA2, BRCA, mutations. She has led international studies resulting in seminal research papers on the topic of treatment of BRCA-associated breast cancer. Dr. Metcalfe is using those research findings to test new models of care to ensure that women have access to genetic testing at the time of cancer diagnosis to make informed decisions about treatment. Dr. Metcalfe, thank you for being here with us today. And we're also joined by Micah, a young woman who brings her perspective living with a BRCA1 genetic mutation. Micah, we're so happy to have you here. Would you like to take a moment to introduce yourself?
Yeah, absolutely. Thank you, Kathy. So my name is Micah Obergewich. I am 20 years old, and this past May, I was tested positive for the BRCA1 genetic mutation. I'm an independent filmmaker based out of Calgary, Alberta, and I like to make films and narratives to kind of bring education on women's health, breast cancer, and of course, BRCA1. Thanks so much for having me here, and thanks for the introduction.
You're welcome. While we wait for participants to start submitting their questions, and of course, we also have submitted questions, I'd like to ask Dr. Metcalfe if you can tell us a little bit about yourself in your own words, your work, and your research.
Sure. Thanks, Kathy. And thanks so much for the opportunity to be here. I think as a scientist, it's probably the most important thing that we can do is to get our research results out to the people who need it the most. So I always welcome these opportunities. So just a little bit about me. I did my undergraduate degree in nursing at Western University and focused on oncology. And at that time, BRCA1 and BRCA2 had just been discovered. And I had a passion for research and recognized that we knew a little bit at that time about what the risks were of developing cancer. But what we didn't know was what that meant for the patient. So if you're told that you have a BRCA1 mutation back in 1996, we really didn't know what to tell you to do about it. Yes, you had this high risk, but how could we reduce that risk? How were women going to make decisions? What did it mean for the family? So there were all of these questions, and that really got me interested. And I did my PhD looking at outcomes associated with bilateral prophylactic mastectomy in women who are at high risk. So those who elected to preventatively remove both breasts before they got breast cancer. And this was a province-wide study. It was the largest study that we had done, that anyone had done in the world, to look at the impact of this surgery. And so my research continues, and I'm very interested in knowing how to use genetic information to make decisions. We've done a lot of work looking at how to best treat breast cancers if a woman knows that she has a BRCA1 or BRCA2 mutation. And we've published a lot on the specific treatments that she should have to increase her chance of survival. So I'm very passionate to ensure that women have access to genetic testing at the time of breast cancer diagnosis. In addition to also making people aware that they may have a risk of having one of these mutations before they even get cancer. So how can we identify those who are at very high risk before they get cancer to ensure that we reduce their risk that they will ever get cancer, or if they are diagnosed with cancer, it's diagnosed at a very early treatable stage. So ultimately, I think my research really focuses on how do we identify people at high risk? How do we use that genetic information with the ultimate goal of reducing the risk of developing cancer and reducing the risk of dying of cancer? So that's a bit about me. I don't know if there was anything else you wanted me to add, Kathy.
No, I think that's fine. And I think as we go along, it'll be a casual conversation and we'll get to know, everybody will get to know each other a lot better. And
Okay.
so I'm going to start off with a couple of questions. And
Okay.
so there'll be questions along the way where the questions will be, what's the difference between hereditary and BRCA and all, the general population and so forth. But my first question is regarding BRCA1 and BRCA2 specifically. So can you just speak to the populations that are most, um, that mostly have the BRCA1 and BRCA2? And since the knowledge about BRCA1, BRCA2, have there been studies in other populations that have become as important and as spread through other populations? And we understand, and you'll correct us, that the Ashkenazi Jewish population is one of the top of
Mm-hmm.
populations that have this gene. So if you
Mm-hmm.
could just give us a little background around that and educate and increase our knowledge.
Okay. So let's start from the basics. BRCA1 and BRCA2 are two genes, and we all have them. And we get one copy from our mother and one copy from our father, and they come together. The issue becomes when there's a mistake in one of them. So it's when there's a mistake. These genes are meant to protect us from getting cancer. And when there's a mistake, or what we call a mutation, it can't work as well to protect us from cancer. So these individuals are at higher risk of developing cancer in their lifetime. It can come from our mother's side. It can come from our father's side. So it's something that's passed on from generation to generation. And that's why we see certain populations that have a higher frequency or a higher chance of having one of these genetic mutations. And like you said, the Ashkenazi Jewish population is one of those groups. And what we know about these genes is there are thousands of different mistakes. And so the mistake or the mutation that Micah has, if it's, I think you said BRCA1, Micah, that's one of over 1,000 different mutations that can be in BRCA1. So Micah has a BRCA1 mutation, but it's probably very different than someone else she knows who has a BRCA1 mutation as well. But it's the exact same mutation that some of your relatives have. So that same specific BRCA1 mutation, it's what's passed down from generation to generation. In the Ashkenazi Jewish population, there are three, so like I said, there's probably over 2,000 between BRCA1 and BRCA2 different mutations. In the Jewish population, there are three common founder mutations. We call these founders because it's something that's within a certain ethnic group. And, it often has to do with some historical context that offspring were being born to people who were geographically in the same population. There were no different genes that were being brought in from different ethnicities. So that's basically how it's much higher. So it's about 1 in 50 to 1 in 100 in people in the Ashkenazi Jewish population have one of these mutations, where it's about between 1 in 250 to 1 in 400 in the general Caucasian population. So it's not common. It's actually very uncommon when we think about it, but it doesn't necessarily. So often we think about these families as families that have a lot of different cancers. So, you could look at a family history and say, oh my gosh, in every generation, we see a lot of breast cancer. We see some ovarian cancer. We may see some prostate cancer in men. But what we know is that, yes, those are high-risk families where we can, almost always identify some genetic mutation. But there are many people where we're identifying mutations now where it was actually kind of unexpected. We didn't see a lot of cancer in the family. Perhaps it's just because of the family structure. There's mostly men in the family. There were few children. So it really depends. And that's not to say that men can't get cancer if they have one of these mutations. They can. There are certain cancers like prostate cancer, male breast cancer, but the risks are not nearly as high as for women, where we see about a 70% risk of breast cancer and up to a 40% risk of ovarian cancer. So these risks are high, and that's why it's important to hopefully identify people prior to a diagnosis of cancer so we can do something about it to ensure that we're reducing the risk of that woman getting cancer in the future.
Great, thank you. But I'm just going to go back to something you said,
Yeah.
other Caucasian individuals. So you're not saying that other populations that are not Caucasians, that,
No, I'm not, but
right.
that's generally. So
I
there
just
are,
wanted to clear that.
yeah. So for example, in Iceland, people who are born and live in Iceland very rarely live in Iceland. So we have very common founder mutations in Iceland. So it's yes. So there has been more and more research that it's being done in Central and South America, and we actually see very high frequencies, for example, in the Bahamas. Women with who are from the Bahamas, their risk of having one of these mutations is actually quite high. So, but I'm not sure that we need to focus on what your ethnicity is. I
Yeah.
think, there are families where it's pretty obvious that there's something going on, but that doesn't mean if you don't have things going on in your family in terms of the number of cancers, it doesn't preclude you from being tested for BRCA1 and BRCA2.
My only question is the only reason I ask is that I know that in certain hospitals across our country, if you
Yes.
come from that Ashkenazi Jewish population,
Yes.
you will ultimately get that test. End
Yes.
story. But
Yes.
there are people that don't come in that are from families and family backgrounds of those that may be missed if they don't
Yes.
get that testing. So
Yes.
this is why I'm bringing it up,
Yes.
primarily because of that.
Yes. So just to go back on that, and I think you've raised a really good point that in Canada, and it doesn't matter what province you're in, there are genetic testing criteria. So you must meet that criteria in order to have genetic testing that's paid for by your provincial healthcare system. Often in those criteria, there is the reference to ethnicity. So for an example, Ashkenazi Jewish. That hasn't always been there. So, which really highlights the importance of research in informing what those criteria need to be. So we did a large study in Ontario, 6,000 Jewish women, no diagnosis of breast cancer. And what we found was of those that we identified with a BRCA1 or BRCA2 mutation, 2/3 of them at that time did not meet criteria for testing. showing us that these criteria are not perfect. But it also helps our policymakers to say we need to change that criteria.
Right.
In Ontario, we have done a pretty good job of expanding the criteria, but it's not like that in every province. So unfortunately, but I still think we have a lot to do in Canada in terms of increasing our eligibility criteria so more people can be tested.
Great. That clears it up. Micah, do you have anything to say on this, or can I move on to the next question?
I do just have a question kind of regarding the criteria for the genetic testing in like within the provinces and such. So myself, my sisters, and my cousins all have the same family history of breast cancer, yet we all had different genetic testing experiences. And I'm just wondering if the province or if the provinces are pushing towards standardizing genetic testing or if Canada is.
That's a really great question, Micah. So your relatives were in different provinces, is that?
We were all based in Alberta.
Oh, you were all in Alberta, but you had a different experience. That's interesting. Alberta actually has probably some of the most restrictive criteria for genetic testing compared to some of the other provinces, which is unfortunate. I wish that Canada would work together and we would have a very, like in the United States, for example, there is more of a national board. It's called the National Comprehensive Cancer Network, the NCCN, and they have guidelines that everyone in the country follows in terms of genetic testing criteria, if you want it to be paid for by your insurance company and that's not to say that you can't go and pay for this test, out of your own pocket. You can, and we can do that in Canada too. If you want the test, you don't qualify, you can pay for that test through a lab in the United States. So that does exist. But I'm not sure as a country if we will ever get to that point where we have consistent criteria, just because healthcare funding is run through the province as opposed to national funding. So we work together across the country as scientists and clinicians to try and inform advocacy to the policymakers in each of these provinces. And it goes beyond criteria. It goes to wait times for genetic testing. And I speak a lot about Ontario because I'm familiar with that experience, but our government in Ontario is very committed to reducing wait times because someone can wait up to 2 years to have genetic testing, and that's not okay. It's not okay that people are on the list to have this genetic testing and waiting, not knowing if they're at high risk. In the meantime, who knows? Someone could be diagnosed with cancer. So there is more funding in Ontario going into supporting genetic counselors so we can reduce those wait times. It's not like that across the country. The Maritimes, for example, have very long wait times. BC, although they're trying really hard to reduce their wait times, thinking about really novel ways of delivering genetic testing and counseling. So I think it's on our radars, and we're all trying to make a difference in terms of all of those issues that I've raised.
Micah, is that fine with you?
Yeah, that was a great answer. Thank you.
Okay.
And then I do just have another question here. As a BRCA1 carrier, does my risk differ whether I live in the city or on a farm?
That's a great question. And so just because you have a BRCA1 mutation or a BRCA2 mutation does not say, yes, you are going to get cancer in your lifetime. So there are some people who don't get cancer, and that's what we're trying to understand. What is it about those people who don't get cancer? What we see is, it's really hard to quantify things like living on a farm versus living in the city, those environmental types of exposures. But we know a lot more about hormonal exposures, so pregnancies, breastfeeding, the use of oral contraceptives, hormone replacement therapy, the age that you got your period, when you went into menopause. So some of those risk factors, and that's what we call them, may reduce your risk of getting cancer, but we can never guarantee it. We can't say if you take oral contraceptives between the ages of 20 and 25, you will not get ovarian cancer. But we can say we think it reduces your risk of ovarian cancer. But especially for ovarian cancer, we need to get your risk down to almost zero. Breast cancer and ovarian cancer are very different cancers. Breast cancer, for someone who's at very high risk, like yourself, Micah, you have access to MRI screening for your breast cancer risk. And we know that that type of screening is more effective than mammography for young women with BRCA1 and BRCA2 mutations. So we have some good evidence now that MRI, women who are having MRI screening present with lower stage cancers and have a higher survival rate. With ovarian cancer, we do not have good screening. So the only option really to reduce a BRCA1 or BRCA2's risk of developing ovarian cancer to a level that we think is acceptable is to have your ovaries and fallopian tubes removed by a certain age. And it's different for BRCA1 than it is for BRCA2 just because of when we start to see those ovarian cancer happening. So I'm sorry I can't answer your question about the farm versus the city, but I don't think we can ever give an answer to say your risk of cancer is down to the general population level, other than through the use of preventive surgery.
Okay, that's great. Thank you. You actually answered a few questions that I had, so that was
good.
Thank you, Micah. They're great questions.
Yes, important questions.
Yeah. Well, speaking from a personal,
Yes, yeah.
lived experience. So my next question would be around it's a big question, around the preventative treatment and measures that are taken once a person is identified as having the BRCA1 or BRCA2. Can you describe the treatment options, and are they the same as they used to be when you first discovered the BRCA1 and how they were treating patients?
So when you say treatment, Kathy, do you mean
Preventative.
prevention? Yeah, these people don't have cancer.
Right.
Right. Okay. So I think what's changed, I mean, intuitively, you would think if you remove both breasts, you're at lower risk of developing breast cancer. Intuitively, you think if you remove your ovaries, you're at lower risk of developing ovarian cancer. But when we first discovered BRCA1 and BRCA2, we didn't have that evidence. Yes, it should be that way, but we can't say for sure. And so let's start talking first about breasts. Let's start with the breasts. So yes, we were able to show that removing both breasts reduced your risk of developing breast cancer. But what we didn't have is the evidence to show, did this actually impact on survival? So yes, we reduce your risk of developing breast cancer, but we have pretty good treatments now for breast cancer, especially if we find them early. And most women survive a diagnosis of breast cancer, right? The survival rates are very high. But we only recently, in the last, I would say 5 years, have that evidence to suggest that yes, removal of both breasts does have a survival advantage for women with BRCA1 and BRCA2 mutations. And I think we have even more evidence for BRCA1 versus BRCA2. For ovarian cancer, again, intuitively, it makes sense. You remove your ovaries, you reduce your risk of ovarian cancer. What we have found in the last, I would say 15 years now, is it isn't just the ovaries. We actually need to take the fallopian tubes too, because there is emerging evidence that the ovarian cancers actually don't originate in the ovaries, they originate in the fallopian tubes. So back in probably the late 1990s, when we were starting to do this surgery for women with BRCA1 and BRCA2, often they weren't taking the fallopian tubes, and they weren't doing a very thorough pathology review. But now that's all very standardized. And if they're doing risk-reducing, what we call salpingo-oophorectomy, which is the removal of the fallopian tubes and the ovaries. Across the world now, there is a protocol on how the pathologists need to look at those ovaries, and they need to look very, very closely to make sure there are no cancers that are just starting that we need to then treat. So I think we've made a lot of progress in understanding that surgery. In the breast cancer space, I think we've also, in the last 30 years, made a lot of progress in terms of thinking of new ways to screen. So MRI screening and how effective that is. We have evidence now that MRI screening does offer a survival advantage compared to mammography screening. So for women who are just being told that they have a BRCA1 or BRCA2, it's scary, right? It's scary to think about that risk and what the risk is of cancer and what am I going to do about it. The first thing we need to do is get a woman into screening, high risk breast screening. I mean, depending on her age, obviously. I mean, Micah, I'm not sure what you're doing, but in Ontario, we generally don't start MRI screening till the age of 30 because we don't see those breast cancers typically before the age of 30. And again, that is family history dependent, so that can change. Depending on a woman's age, the priority, so if she's 40 or above, the priority is the ovaries. We do not want her to get ovarian cancer. So that generally becomes our priority. So get her starting her screening, her breast screening, but we really need to think about, depending on BRCA1 versus BRCA2 and what age. But for BRCA1, it's generally between the ages of 35 and 40. For BRCA2, it's a little bit older, like 44, 45, 50-ish, because we start to see those cancers later in BRCA2 versus BRCA1. So again, it's so dependent on the woman, her age. Does she still want more children? Because that, that impacts on her decision about her ovaries. So it is a very individualized decision. So there isn't a prescription to say you are this person, you must do this. It is a conversation. It's generally an ongoing conversation depending on the woman's age. But yeah, that's generally what happens. I don't know if there's anything you wanted to add, Micah, about your experience.
Um, I just have a quick question about this, I guess,
Yeah.
specifically with the ovarian cancer
Mhm.
prevention methods. So, I've been recommended to seek ovarian cancer prevention before I'm 30 years old. And given my strong family history with cancer, I'm a little bit worried about it. So, what kind of prevention methods would you recommend for me? And are you able to tell me a little bit about the research behind these methods?
And I'm not going to give medical advice. I'll just tell you what we would tell any woman. So when you talk about cancer prevention, are you talking about ovarian cancer prevention or breast cancer prevention?
Ovarian cancer prevention for this question specifically.
Okay. So we do have some evidence on the effectiveness of oral contraceptives for the reduction in risk of ovarian cancer. And I'm not sure what your family history looks like, but 30 seems pretty young for removal of the ovaries, unless there has been a very young onset ovarian cancer in your family. That seems quite young. Um, and it's not just because of the surgery, it's because all of the implications that go along with the removal of ovaries when you're 30. Um, there's a lot of research right now going into can we delay removal of the ovaries even a little bit? So there's research now looking at, and we're doing some at Women's College in Toronto, can we remove the fallopian tubes and buy a little bit of time for the woman until she has to have her ovaries out, just to have even an extra 5 years to have your ovaries and all the hormones, because we know the importance of those hormones, as you become an older woman, because you will, because, thinking about how you're reducing your risk of cancer. But there are, issues with early menopause when thinking about osteoporosis, heart disease, cognitive functioning. So it's really important for women who are having their ovaries removed at an early age to be involved in a clinic with a specialist who knows how to manage some of the symptoms that come along with that, but also thinking about how to support that woman. So there's a lot of research going on right now in hormone replacement therapy, and we have some good evidence now that it may not be harmful, so it may not increase your risk of developing breast cancer, for example. It actually may be beneficial. Most women who have a oophorectomy, at least in Ontario, I suspect it's similar across the country, will be put on hormone replacement therapy for a short amount of time at least, to ensure that you still have the advantages of those hormones in terms of some of the other long-term consequences of having your ovaries out so early. So I think it's worth, you're only 21. So by 30, things may change and we may have even more evidence, because I think there's a lot going on in this space right now about the ovarian cancer prevention and how to support women who make the decision to have this surgery done at a young age.
All right. And also, I'm part of quite a niche group of people who are at high risk but haven't had breast cancer. Do you know where I can go to find support for people like this?
Yeah, that's another great question. There's a great support group that's out of the US, but many of our Canadian patients go there too. It's called FORCE, Facing Our Risk of Cancer Empowered. I think it's a very credible source of information. It's internationally recognized by us as scientists and clinicians. I feel like the information that they're giving out is accurate. It's all based on, they're presenting the latest research findings in an easy to understand way. There's opportunities to participate in research studies. So that would be, I think, the number one choice for someone to get some information and connect with other people. There's peer support. So I think that that's a good place to start.
Awesome. Thank you so much.
You're welcome.
Thank you, Micah. So I have a last question for you. In terms of education and understanding BRCA1, BRCA2, how much have we improved since the discovery of the BRCA1, BRCA2?
Oh, I think we've made huge progress. I think when we first discovered this, the focus really was on people with cancer. We didn't test people until they got cancer. I think we've made really good progress. I still think we still have far to go. I think we can offer a lot of guidance and recommendations based on evidence now about the most effective way to handle this risk. I think we know more, not even just about the physical, medical consequences, but also the psychological and psychosocial and family dynamics. There's a lot of research that's going on in that area as well, helping people to make decisions about what's right for them. I think we have great support groups, like I've just talked about with FORCE. I think what's happened in the last 10 years, though, is that we're going now beyond BRCA1 and BRCA2. So typically, you're not just tested for those two genes, you're tested for a whole panel of breast cancer predisposition genes. And so it includes BRCA1 and BRCA2, but there are often many other genes, PALB2, ATM, CHEK2, and the list goes on. For those genes, the risks of cancer are different. And we're almost back to where we were with BRCA1 and BRCA2 in knowing how to best manage patients with these mutations. So, and that's not to say that we know everything now that we need to know about BRCA1 and 2. We don't, but we know a lot, and we're still trying to figure it out in general for these other genes. So there are a lot of international efforts. I'm leading some of them in PALB2 and ATM, looking how to best treat these cancers. So for women who are told that they have a mutation, or men for that reason, for that same reason, we know less about how. We know about their cancer risks, generally, but we're not sure exactly how to best manage those patients because we don't have the evidence. We're kind of back where we were with BRCA1 and 2. Yes, we know you're at high risk, but what is that risk-benefit ratio when we're thinking about some of these interventions that we're talking about? Preventive surgery, taking medications to reduce your risk of developing cancer. Is it that same risk benefit for some of these other genes as well? So I think there's a lot of focus on that now in terms of research. And we're also still looking for, are there other drugs that we don't know about yet that may be effective in reducing the risk of cancer? At University of Pennsylvania, they're trialing immunization. I can't even think of the word. It's late on a Friday. Vaccines.
Vaccine.
So there's, although who knows what's going to happen in the US with that, but there still is so much ongoing research. The research about just removal of the fallopian tubes to buy some time, and then the removal of the ovaries. There's research going on in that as well. So yes, I still think we have a lot to learn. I think we need to think about better options. 25, 30 years ago, did I think we would still be telling women the best option is to remove your ovaries, to remove your breasts, to ever, prevent getting cancer? No. I thought we would be maybe further, we would have some more. The thing is, we do have some drugs. Tamoxifen is a drug that there is some evidence that it reduces the risk of cancer in BRCA1 and 2, but most women don't want to take a medication to reduce their risk of developing cancer. They're generally they're having MRI screening, or they've elected to have both breasts removed. And in Canada, it's about 30% of women with BRCA1 or BRCA2 elect to have that surgery. So again, it's such an individual decision.
It is. Thank you. Micah, do you have any other questions at the time?
In terms of getting preventative surgeries like a mastectomy per se, would you still be considered high risk if you choose to do nipple-sparing mastectomy?
Good question. Again, we have much more evidence about that now too. And initially, when like back in the 1990s, when we were recommending this, absolutely not would any surgeon keep a nipple areolar complex because there's a little bit of tissue left behind. But we now have some evidence that it's okay, that the risk isn't high like we assumed it might be. So that's a discussion that a woman needs to have with her surgeon. What is it? How do they look at the tissue underneath the nipple and areolar that remains after this surgery? Again, it's a very small amount of tissue. And if the surgeon generally knows that they're operating on someone who's at very high risk with a BRCA1 mutation, they're going to remove as much tissue as possible. So that is an option. It's not an option for every woman just because of a woman's anatomy and size of breasts, etc. So it may not be an option, but it is a conversation to have with your surgeon.
Awesome, thank you. And also, would my risk be similar to my mom's diagnosis in terms of age and cancer subtype?
Good question. Gosh, Micah, you have so many good questions. It's amazing. So generally, we look at a family history and the ages of cancer to guide decision making. So, for example, if there's a young 25-year-old in your family who had breast cancer, we will start your screening much younger than the average BRCA1 or BRCA2 carrier. So we think, and to my knowledge, I can't think of any evidence that shows that, but we wouldn't want to miss those cancers because, we didn't want to go outside the guidelines. So we would generally start earlier. But that's not to say, I mean, it's the same thing as saying, there's ovarian cancer in my family. Am I absolutely going to get ovarian cancer? Nobody can tell a woman that. Yes, we think you're probably at higher risk. We have some evidence that the more family history, the more first degree relatives, so those are your mom, your sister, your child. If she had a diagnosis of ovarian cancer, you're at a higher risk of ovarian cancer. You have the BRCA1, but you're at higher risk than a BRCA1 carrier without a mother with ovarian cancer. So we would counsel you on that increased risk. But there's no black and white in this. There's no saying, yes, you're going to get it, and yes, you're going to get it at this age, or no, you're not going to get it. So generally, we advise people to look at the ages of the family history and screening and prevention guidance would be based on that.
Thank you. That's really insightful.
Okay.
Thank you, Micah.
Great.
So if we continue on, in terms of hereditary and familial breast cancer, can you give us a little bit of what the difference is and how people
Yes.
get confused with that?
Yes. Okay, so if I was to make it as simple as possible, hereditary generally refers to something that it is a known gene that's being passed down from generation to generation, whereas familial is generally that there's cancers in the family, but we can't identify a gene. So it looks suspicious, but there's no known gene that we can test for that explains what's going on in the family. So that's generally how we quantify risk. So someone, for example, if it's hereditary and you have a BRCA1 mutation, we would give you a risk based on that BRCA1 mutation. Whereas familial, we can't identify any mutation in anybody in any gene, but we know there's family history. So you're not the general population risk of developing cancer, you're higher. But it's sometimes difficult to quantify how high that is. And it could be, high. It could be 20, 30% risk of developing breast cancer. I think this is where it's really important for people to have a conversation with a genetic counselor. These people are so knowledgeable about what's going on in your family, and they can help you to understand. Often there are things that can just, sometimes people think, oh, I have breast cancer on my mom's side, I have breast cancer on my father's side, that must be worse. I must have even higher of a risk. And that's not the way it works. So it's important to have those conversations and understand what's going on in your breast cancer or in your family. Back in generations past, people didn't really talk about cancer. Breast cancer maybe because maybe you knew about their surgery, but things like ovarian cancer, it was abdominal. Nobody would say ovarian. There's a confusion with cervical cancer, and cervical cancer is not ovarian cancer, and cervical cancer doesn't go along with BRCA1 and BRCA2. So really teasing out what's going on in your family is really important to understand risk.
So I have a question in terms of when they say there's a lot of cancer in the family, how does research and medicine identify a group or a family that has high risk in their family because so many members have it? Is it based on age? Like if cousins are diagnosed later in life, like after 65 with prostate, or I'm just giving
Yes.
an example, a colorectal or any of those things that
Yes.
may happen to any one of us as we get older, does that mean it's in the family or is that age? Like, how can you?
Yeah, those are all really good questions. And when you go to see a genetic counselor, they actually take all of that information. So we ask about your cousins, your aunts, your uncles, your parents, your grandparents, great-grandparents, and we can take all of that information about. So we look at the number of relatives in the family on both sides. We look at the types of cancers. We look at the ages of diagnosis of those cancers. We look at ethnicity. all of that information can actually go into a model, and you put all of that information in and it spits out a number. In fact, Micah, you probably had this in your, well, maybe not because there was already a known BRCA1 mutation in your family, but the first person in your family who went in probably had this done. And it gives you a risk. What is the risk? What risk do we think you have of actually having a BRCA1 mutation or a BRCA2 mutation? And some of these other genes that I talked about earlier. What do we think, based on all of this information, your lifetime risk is of developing breast cancer? So all of that can be quantified, and we can give you a number based on all of that family history information.
Thank you.
Okay.
And how common is hereditary breast cancer compared to non-hereditary familial breast cancer?
So the majority of breast cancers are not hereditary. They are, we can't explain why, but the majority are not hereditary. So it's about 10%, thinking about all of these other genes as well, that are hereditary. More and more, our genetic testing criteria across the country are getting a little bit more relaxed because we know the importance of genetic testing in a woman with breast cancer. It has not only important information for that woman in trying to understand why she developed breast cancer, but we now have targeted treatments that are much more effective and will be offered to you only if you have a BRCA1 or BRCA2 mutation. So there are medications called PARP inhibitors that can be given to patients who meet criteria, and one of the criteria is that she has a BRCA1 or BRCA2 mutation. So it's much more important now that we relax those criteria for genetic testing for a woman with a diagnosis of breast cancer at the time of diagnosis. Again, varied across the country. So in Ontario, it used to be 40. It's now gone up to 45 or 50. So it keeps getting older. So the more people that can be tested, the more we're going to identify with a BRCA1 or 2 mutation who will be eligible for some of these drugs. So, and now I even forget your question, Kathy, but it is important for women to advocate for yourself at the time of breast cancer diagnosis that you want this test. For some women in some provinces, you won't be eligible, but you can pay to have this test done. And it's about $500, which is a lot of money, especially for us as Canadians who are not used to paying for healthcare. But it may be something that you want to consider doing. And generally, the test happens pretty quickly, and you get those results back before you initiate treatment. So treatment decisions can be changed based on the genetic information that you get back.
Is that test included in genome testing?
Genome testing of the tumor?
Yeah.
It is and it isn't. So are you talking about something like Oncotype?
Yes.
Yeah, no, it's not. You wouldn't get those genetic test results. This is a blood sample or a saliva sample that you give. Some institutions are now testing the tumor for BRCA1 and 2, but it really is on a research basis.
Okay. And there's a question about research and about prevention options for hereditary versus non-hereditary familial breast cancer. And what are the remaining gaps around that?
I think we've talked a lot about BRCA1 and BRCA2. Like I said, there are these newer genes, and now that we're offering this testing for some of these newer genes, we have to think about what the prevention options are for them based on their risk of cancer. I think there's research going on in that. Going back to BRCA1 and 2, there again, like I said, there's some research in prevention with other medications that may be given for other indications like osteoporosis, prevention of osteoporosis, where we're actually seeing a reduction in the risk of cancer. So there's more trials going on in that now to see if those drugs actually would reduce the risk. I don't know that we'll ever have a drug that brings the risk of cancer in our BRCA1 and 2 carriers down to zero, like surgery almost does. I'm not sure that we'll ever get to that point. We may. For the non-genetic families where there is an increased risk, again, depending on the province that you're in, advocating for breast screening using MRI. We know it's more effective in picking up these cancers than mammography. That's something to think about. Ovarian cancer in your family, worth a discussion with your healthcare provider on whether or not removal of the ovaries is indicated for prevention, even if you don't have a BRCA1 or 2 mutation. Again, something to talk to your doctor about.
Thank you. I think at this time, we're going to hand it over to Rebecca to ask if she has any questions that have been submitted live.
Thank you. Yes. So we have one question. You touched on it a bit in terms of the survival benefits of surgery for preventative BRCA mutations, but just to make sure that we, drive the point home and that it is clearly expressed to her. She's asking, is there a difference between the length in life of those who choose a preventative double mastectomy and those who opt for surveillance?
Yes, and there are very few studies that have looked at this outcome. In fact, there's about 5 in the world. We did one of them at Women's College. Yes, it does offer a survival advantage. In fact, very few women who have what we call risk-reducing mastectomy will ever get breast cancer. However, it's not zero. And what we see is that for the very few people who get breast cancer after this surgery, and I mean it's very, very few, especially as time has gone on and surgery has become much more, the surgeons are much more focused on removing all of that breast tissue. If a woman gets breast cancer after a risk-reducing mastectomy, and again, very, very rare, the problem is that cancer doesn't present in the breast because there's no breast tissue left. So it often presents as somewhere distant in the body. And once it presents somewhere distant in the body, it's very hard to treat that cancer. So for many, and I'm like thousands of women that we looked at, and we had 4 in our study. So it's very, very, very rare, but it's not zero. What we do have evidence on is oophorectomy, so the removal of the ovaries. This surgery offers a 70% reduction in all-cause mortality. So for a woman who has this surgery, she reduces her risk of dying by 70%. And it speaks to the profound impact of ovarian cancer on survival. So even if a woman has had a breast cancer diagnosis, this is a surgery that we recommend. It not only reduces her risk of ovarian cancer, it reduces her risk of developing a new breast cancer in the opposite breast. And it has an impact on survival in women with breast cancer. So it's a very important surgery. In terms of when we're thinking about survival. So if that was the one piece of advice I could give any woman with a BRCA1 or 2 mutation, it's the importance of having your ovaries out at the right age. We've had some unfortunate situations that women delayed and delayed and delayed. And then, yes, I'm going to have the surgery next year. I'm going to have it next year. And they presented with ovarian cancer. And once you have ovarian cancer, the survival rate is not high like it is with breast cancer. That's not to say that it hasn't gotten a little bit better over time, because we now have some of these new drugs that actually are specifically for BRCA1 and BRCA2, but the survival rates are still not high like we'd like them to be. So, in terms of prevention, that's probably the number one. In fact, when we look at the guidelines on how to manage women with a BRCA1 or 2 mutation, risk-reducing mastectomy is an option. There's no recommendation that they need to have it. It is, yes, talk to your doctor. If it's right for you, it might be right for you. But with ovarian cancer, there's not a talk to your doctor. This is a recommendation at this age. So it is very different in terms of how we counsel women about these risks.
I have a follow-up question. Is this the same, in your opinion, for non-BRCA1 and 2 breast cancers, especially those who are hormonal positive?
Again, a discussion with your doctor. It
I'm talking
depends.
about ovarian. I'm talking about ovarian, oophorectomy.
Oh, oophorectomy. Well, the risk of ovarian cancer in the general population is very low. It's about 1.5% of women will get ovarian cancer. So it doesn't make sense to suggest that all women have an oophorectomy, but we do see in some places, BC is one of those places, where if they're going in to do another abdominal surgery, those women are offered the option of having their fallopian tubes removed. So, because there is some evidence that removing the fallopian tubes reduces the risk of developing ovarian cancer. So, if the surgeon is already in there doing another surgery, it's very easy to just take the fallopian tubes out. So, and that's called an opportunistic salpingectomy. And BC is really leading the way in that, looking at that surgery. So, is that to say that if you're going in to have your gallbladder removed, could you mention it to your surgeon? Sure. Um, we don't really need our fallopian tubes for anything after we're finished having children. So, it's not the removal of the ovaries. The ovaries stay. It's the fallopian tubes that come out.
And if my question around the surgeries and all the surgeries that you mentioned that are pretty much the standard of how they are going to treat patients, is that standardized across the country? Are individuals getting the same treatment across the country?
Treatment for cancer?
No, for the surgery, for ovarectomy.
For prevention.
Yeah,
Yes. Yes.
they are?
Yes.
Okay, that's good. That's good to know.
Yeah.
That's good to know.
Yeah.
So I just have one more patient submitted
Yes.
question, and then we can go back to you for a bit. So someone's asking, and I'm gonna ask my a clarifying question on this to maybe
Okay.
it'll answer her question. She's specifically asking about radiation being a protective after a lumpectomy. I'm gonna focus more on, is lumpectomy something that is ever considered or offered to someone who has a genetic mutation?
Yeah, good question. Yes, it is. So women have the option of a lumpectomy and radiation, or a unilateral mastectomy, or a bilateral mastectomy. For BRCA1 and BRCA2 carriers, the issue is having the bilateral mastectomy is not going to have an impact on your survival, because, removing the opposite breast is not going to impact whether or not you survive from that first breast cancer. That first breast cancer is already there. So, the focus needs to be on treating that first breast cancer. For BRCA1 and BRCA2 carriers, the issue is they have a high risk of developing a new breast cancer in the opposite breast. So by having a bilateral mastectomy, you're reducing your risk that you'll get a contralateral breast cancer, so a breast cancer in the opposite breast, which for some women, they never want to go through this again. For other women, it's important that they keep their breast. So it is an option. And again, a very personal decision. for women at the time of breast cancer diagnosis. And another reason why it's important to have genetic testing at that time, because it can help a woman make a decision for, even to get a negative result that maybe says, okay, I'm good, then I don't need a bilateral mastectomy. There is this misconception, and I think it's not unique to Canada. In fact, we're probably less obsessed with this than they are in the US, about having a bilateral mastectomy at the time of breast cancer diagnosis, even if you don't have a BRCA1 or 2 mutation, because there is that. And of course, a woman, wants to survive for breast cancer, and she thinks if she has more surgery, she's going to have a better survival. And that's absolutely not true. We have very good evidence that that's not true. But for some women, that just is the decision they want to make. So, but for other, they might be on the fence. And so to get a negative genetic test result may help them to make the decision to not have a bilateral mastectomy. It is a much bigger surgery. There is more risk associated with having a longer surgery, both breasts removed. But for BRCA carriers, it is indicated. It's perfectly acceptable to have a bilateral mastectomy because of that increased risk of a contralateral breast cancer.
Thank you.
Thank you. I think, Micah, if you'd like to ask some of your questions, please go ahead.
I think the only question I have left is just about if I were to have any children or offspring, what is the risk that they also have the BRCA1 genetic mutation?
Yes, and that's an important question to ask. So with every pregnancy, it is a 50% risk that it's passed down. And that doesn't mean that 50% of your children will get it and 50% won't. It is like a flip of the coin every pregnancy. So we have some families where there are 4 children and none of them inherited it from their parent because it really was just the flip of a coin. And then we have some families where 4 children all got it. So again, it is a conversation. Some people are interested in having they're going for fertility treatment or going to see a fertility specialist to talk about this, because you can make a decision to do pre-implantation genetic diagnosis on the embryos. And some people choose to do that and to test if the embryos have BRCA1 and BRCA2 and not implant those embryos. But, that's an ethical consideration. It's a very personal decision to think about that. There's a cost associated with it. So, this isn't like a condition where it isn't 100% guaranteed that you're going to get cancer. We can do something about reducing the risk of getting those cancers. This isn't a disease like Huntington's disease, for example, where if you have that genetic mutation, you will get Huntington's and it will, greatly affect your life. This isn't like that. So, but those are options that are available to individuals who have a mutation in BRCA1 or 2.
Thank you.
You're welcome.
And you said this isn't, like Huntington's, that we can't pinpoint it, because breast cancer, as we've all learned over time, is so confusing. It's so complex, right?
Yeah,
And it
yeah.
isn't. In some areas, it's fine. This is what we're doing. And that there, but the bigger picture is quite complex, right?
Yeah.
And how do you see research bettering in terms of understanding how to streamline all this? In terms of care, understanding, treatments, moving forward?
Yeah. I mean, in the breast cancer space, I think breast cancer in general, and I'm not even just talking about BRCA1 or 2, I think in the last 10 or 15 years that the progress that has been made in terms of first of all, screening. So, identifying cancers earlier, we've made great progress in that. But the treatments that are available now and that are so targeted to the specific breast cancer, and it's important to remember that breast cancer is not breast cancer is not breast cancer. What they can do now to look at the unique tumor that each individual woman has and determine how to best treat that, I think the progress that has been made in that space is really incredible. And you hear the buzzword about personalized treatment. Well, it really is personalized cancer treatment now, especially in breast cancer. So you or your neighbor both have breast cancer, the likelihood that you are receiving the exact same treatment now, it's not as likely as it was in the past. So I think we're making really good progress there. I think we still have a long way to go from a public health perspective, especially in genetics, and thinking about, do we get to the point ever that any Canadian who wants to know this information can have the genetic test done? When you turn 25, is this something, it's a one-time only test. It's not like we're doing PSA every year, every 2 years, or your vitamin D levels. This is a one-time test. And do we ever get to the point where this is a one-time test that any Canadian can have access to? And just think about the impact that that could have.
Mhm.
Identifying people who are at high risk of developing cancer and making sure that we do everything together to ensure that they either don't get cancer, or if they do, it's at a very early treatable stage. So that would be my vision. I would love to see us get there in my lifetime, that anybody who wants to have this test can have this test done.
Thank you. Rebecca, do you have submitted questions? Live questions, because I have more submitted questions.
Yeah, I do have you talked about breast cancer being so many different diseases in one. But we know there seems to be like a strong connection between BRCA1 or BRCA, sorry, and triple negative disease. Do we know what that connection is, or why it tends to be more common in triple negative disease?
It's a good question. And it would be very complicated to go into the biology, but it's unique about BRCA1. It's not, BRCA2 is general. I mean, yes, there are some triple negatives, but BRCA1 is predominantly triple negative. And but that's not to say that if you have triple negative breast cancer, you're going to have a BRCA1 mutation. Although you are more likely, if you're diagnosed with triple negative breast cancer, your risk of having a BRCA1 mutation is higher than someone who has ER positive breast cancer, for example. So thinking about that, it's important. And triple negative breast cancer is actually in Ontario anyways, is an eligibility criteria for genetic testing. So if a woman is diagnosed with triple negative breast cancer at any age, she's eligible for genetic testing. That is actually when we did a study looking at women at the time of breast cancer diagnosis, the triple negative breast cancer group was actually the ones who had the highest risk of having a BRCA1 mutation and some BRCA2 as well. I'm not sure if that answers your question, Rebecca.
Yeah, I think it does. You talked about the PARP inhibitors.
Yes.
And I know they're given to help people, I guess, lower their risk if they have BRCA mutated breast cancer. Is there any evidence to show that they could be used in a preventative way for people who don't have breast cancer yet? Or no?
There's always a conversation about that at conferences and things like that. Could we use PARP inhibitors? First of all, they're very expensive. They're very expensive.
Mm-hmm.
And they have significant side effects. And are we going to ask a 30-year-old woman to take olaparib? How long do we ask her to take it? There are so many questions. And we know with drugs like tamoxifen, where yes, there is a side effect profile, but it's not like olaparib. And we know women are very reluctant to take tamoxifen to reduce their risk
Mhm.
of developing breast cancer. So do I see us ever getting there? Probably not.
Great.
Thank you.
Is that it for the live questions?
For now, yes.
Okay. So we're going to go into fertility a little bit. We have some questions that were pre-submitted. What does the current research tell us about the impact of hereditary breast cancer on fertility and reproductive outcomes?
Generally, we don't think there's any impact. We just did a recent study where we saw a lower level of AMH, which is a hormone that tells us a little bit about how your ovaries are behaving and how old your ovaries are, basically. And we saw the AMH levels were a little bit lower in BRCA1, but we don't see how that's translating into women with BRCA1 or 2 mutations having lower rates of fertility. We have no evidence that that exists.
Okay.
So we don't think it does.
And what evidence
But
do we
that's
have?
not to say, Kathy, maybe I can just even, we do talk to women, especially BRCA1 carriers who are in their 30s. Sometimes it's worth a conversation about family planning. When are you planning on having your children? Because when you're pregnant, you can't be having MRI screening. So there's a lot that goes into some of those family planning decisions about when to have your children. How quickly do you want to do this so that you can think about having your ovaries removed at the age of 40? What is that going to do to our screening? How do we time the MRI screening and things like that? So it is a conversation, and it's an important conversation to a woman, for a woman to have when she's in that family planning type of age group. And it's an important conversation to have with your doctor.
Okay. And another question was, what evidence do we have about the safety and effectiveness of fertility preservation strategies in people with hereditary cancer treatment?
There have been a few studies done, and we've not seen any negative impact of
Yeah.
like IVF drugs. Is that what the question's about?
Yeah.
Yeah, no.
Okay. Okay. And as we put all these pieces together, of course, we're a big country, and like you said, provincially, we have different ways of treating patients and, doing things. What is the standard best way of a young woman, just like Micah, learning that it has inherited the BRCA1 or 2, because it could become confusing, right? Who do you talk to once you learn all this? Because I'm sure there is a step-by-step. You see counseling. You have to seek, preservation for ovaries, depending on the age. Uh, how is the best way that a person should approach this and advocate for herself?
Yeah. And I think it's such a personal thing. I mean, Micah is 20 years old, I think you said, right, Micah? Um, Often, there are very few 20-year-olds who have been tested already. Legally, we can start testing at the age of 18, and some people want to know right at the age of 18. Others don't want to know for a while. Generally, unless there's an indication in the family that it's an early onset cancers, like cancers in the 20s, we talk to women about, is this the right time for you to have genetic testing? Do you want to delay it? We're not going to do anything different. We may start mammography a little bit earlier, but we're still not going to start MRI till the age of 30. So it's a very individual discussion to have and to come to that decision that this is the right time for me. So depending on the age that you're told really changes, being told at 20 and being told at 40 is going to be very different. We're in much more of a rush at the age of 40 because we know that woman is in the age group where we see these cancers happening. So, but with a 20-year-old, it's, she has some time to think about what she wants to do with this information and how. And who knows what we might discover in the next 5 or 10 years when we start to see her cancer risks start to go up. So Is there a prescribed map for everybody? No. Again, whether you've had a diagnosis of cancer or not will determine, may have an impact on your choices and how quickly you need to make a decision. So, at Women's College in Toronto, we actually have a clinic that follows patients who have a BRCA1 or 2 mutation, and trying to think about it multidisciplinary. We have breast, we have screening, we have prevention, we have the ovaries, we have a social worker, we have the genetic counselor, really to help, because this isn't a once in a lifetime kind of conversation. This is something that stays with someone for their life. And there may be times when a woman or a man wants to check in with their genetic counselor because now it's time I need to tell my children. Can you help me in figuring out how I'm going to do that? Or, I learned at 20, I'm now 30. Have things changed in terms of the recommendations? Because recommendations do change over time. So it is worth staying connected to your genetic counselor or your genetics clinic. And I think we're so fortunate in Canada because everybody is tested through a genetics clinic, and they have that genetic counselor, as opposed to in the US where anybody can order genetic testing. So I think we're fortunate that way, and I would encourage people to stay connected, or if they're not, to reconnect when you need um, to ask some of those questions, because you may think of things in another 10 years that you didn't think about right now because it may be unique to whatever you're going through at the time. So yeah, that would be my take-home message on that one.
Great. Micah, do you have any follow-up question around this? I see that you might.
I don't have any follow-up questions about this, but that was really good information. Thank you.
Okay, great.
Good.
Do you have any live questions, Rebecca?
Sure. Just in keeping with the genetic specialists and kind of rechecking in, what about for, going back to people who do have strong family histories, but they don't end up having a genetic mutation that we know of? Would they still, in 10 years, let's say, be able to reconnect with a genetic counselor if there is
Of course.
perhaps,
Yes.
more genetic tests that or mutations that have kind of come out? Do you recommend people kind of following up and getting retested if they are in that position?
Yeah. So like I said, we've changed genetic testing in the last, I can't even remember what year it was, but say the last 5 to 10 years, and that we now offer more than just BRCA1 or 2. So some of those early families may just have been tested for BRCA1 and BRCA2. So it's worth going back to your genetics to say, I was only tested for BRCA1 and 2. I heard you now test for a whole panel of genes. I need to get that done. And often a genetic counselor would have that conversation that sometimes we test the wrong person in the family. So, for example, if there's no known mutation and Rebecca, you show up in the genetics clinic and say, I've never had cancer, but look at my family history. I have all of these breast cancer cases. I'd like genetic testing. Typically, what we'd like to do is start with someone in the family who's had a diagnosis of cancer because it's much more informative.
Right.
But if those people are not available, they live not in Canada, or none of them are still alive, we could test you. But if you have a negative result, it's not really that informative. It may be that your mother had it, but she just didn't pass
It
it to
didn't get passed
you.
down.
Or it may mean that no, there really isn't anything going on in the family. So if a new family member is tested, so for example, Rebecca, you have a cousin that is diagnosed with cancer, it'd be really important to get that cousin tested and to see does she have a mutation? And maybe she does. And that would show you that, yes, there is a mutation in this family that's explaining all of these cancers, but I didn't inherit it because I've tested negative. So, yes, I think you can always go back. If something in your family changes, or if you only had testing for BRCA1 and BRCA2, it's worth going back and asking for more testing.
That's very helpful. Thank you. And I just have one more question. I think that this is a good place to kind of leave some of these live questions. Do you think that one day BRCA mutations will be able to be repaired?
Maybe.
Is there any research being done on that?
I mean, there's research being done on gene therapy, and that's kind of where it would lie. I don't know in BRCA1 or 2 if that's, I haven't heard anything about that happening right now.
Thank you.
Okay.
Back to you, Kathy.
I think I forgot to ask you, BRCA1, BRCA2, did we cover the difference?
A little bit, I think we've talked about. So they have the same function, BRCA1 and 2, and it's to protect us from developing cancer. BRCA1, a little bit higher ovarian cancer risk.
Wow.
BRCA2, we have different cancers associated with that too. So male breast cancer, prostate cancer, increased risk of pancreatic cancer, although it's not that high. But it's compared to the general population. So yes, BRCA1 breast cancers we typically see younger than BRCA2, and that's why the recommendation for thinking about when we're thinking about cancer prevention, it's really based on when we see these cancers happening. Higher risk of ovarian cancer with BRCA1, and that's why we recommend the ovarian surgery earlier. And we see those ovarian cancers a little bit younger. But those are the main differences.
And do you see more of one than two? It sounds to me like if you do ground research and hearing people describe their cancer, it sounds like it's more, they'll say to you, I have BRCA1, is that?
Yeah, and I think we originally thought that, and I think it's because we were testing more people with that were at higher, like had higher risk looking families. But if we do more testing and don't think about the eligibility criteria or don't think about, just testing the triple negatives, well, if we just test the triple negatives, we're going to see more BRCA1 than BRCA2.
Okay.
But if we think about general population testing and not taking any of these eligibility criteria into consideration, it would be pretty similar.
And is there a different description for a patient that gets BRCA1 or 2 from a
Yeah.
father or a mother? Do you have a
No,
different classification?
no, it's the same.
Same. So it's not in
No.
the old days, they used to think that there was a difference.
Yeah, no, it's just
The
as likely to
mother
come
and the
from your
father.
father's side as your mother's side.
Right, and that's why I'm asking the question. I'd like to
Yep,
get it out there and
yep,
clarify it, make sure
yes,
that everybody's on the same page.
yep,
Because even today, I hear that often. And I'm
yes, me
oh,
too.
no.
Yes,
Oh, you do, right? Is
yes,
no,
yep,
no. Yeah,
yep. So it's really important for people to look at the family history on their father's side in addition to the family history on their mother's
correct.
side. Yes.
Yeah, yeah. So, as we draw almost to the end of this amazing webinar, what do you see in the future in terms of everything? Personalized treatment, understanding this
Mhm.
better, options. How can you give us some takeaways and
Mhm.
look, there are things coming down the pipeline to.
Yeah, I think the whole idea of personalized cancer treatment will continue to evolve and I think that's very promising. But we also need to think about prevention and how are we going to prevent cancers unless we can identify who's at high risk? So until we do a better job identifying who's at high risk before they get cancer, it's going to be really hard to focus on prevention in these high risk families. And I'm not talking about general population cancer prevention. I'm talking about families where we know there's something genetic going on. So I think that's where we can really have an impact, that if we identify more people and do something about those cancers ever happening, we're going to have a significant impact.
Mhm.
But we need to do a better job of testing before people get cancer. And our criteria for genetic testing are so focused on those with cancer that I think we're missing an opportunity to test those without cancer. And I'm very focused on that. I have a few studies going on now where we're doing what we're calling population genetic testing. So it's important to understand how many people in the general population have these mutations, but is this acceptable to people to have this testing and then be surprised when they're told they're positive because they had no family history, and we do have those kinds of families. So we need to gather that evidence to look at the impact of this population genetic testing, not only on the psychological functioning of the individual, but what do they do with this information? So if they have the genetic test and they don't end up going for better screening or looking at preventing those cancers, it's really not beneficial. But if we know that people use this information to make decisions to lower their risk of ever getting cancer, I think that's where we can make a real impact in terms of preventing cancers in the future.
Thank you. And I'd like to give Micah the last word, seeing that Micah is the person with the lived experience.
Mm-hmm.
Anything you might want to say to the general audience?
I just want to say thank you to you guys for having me. I thought this was a super insightful session, and I'm really glad that I could be a part of this. And I hope that everybody else was able to find this as insightful as I found it, because I found this answered a lot of my questions that were outstanding.
Great. Thank you. Thank you very much. And with that, I'm going to thank you both, Dr. Metcalfe and Micah, for this great and engaging discussion. You both did a wonderful job in answering and, giving personalized feedback yourself, Micah. Thank you. That really is very, very meaningful. And this brings our session to a close. Thank you to everyone for all the excellent questions that you submitted and asked on live online. I'd just like you to know that after this session, you will be sent a survey to provide feedback on this session. Your responses will help us make these sessions better. And once again, I'd like to thank our sponsor, Pfizer, Gilead, Bayer, Tessera, and AstraZeneca. So everyone, thank you again, and have a great afternoon.